Okay, everybody, take 97. Let's see if this time it actually works well. All right, we're going to be picking up with chapter 29 since it's been a couple of weeks with quote unquote spring break in there and then our week of skills. It's been a little bit since we've touched on this chapter, so I'm going to quickly go through the stuff that we've already covered. Please refer back to your notes for this stuff. And then obviously, since it has been a while since you've probably touched on it, let's not kid ourselves. Um, go back through and review the reading that hopefully you've already been done. That's already been done a couple weeks ago. All right, so let's start out with the A&P, the nervous of the nervous and skeletal systems here. All right, so our nervous system. Obviously, it controls our thoughts, our emotions, our hopes, our dreams, all that kind of stuff, along with our sensations and motor functions. Our central nervous system consists of the brain and spinal cord, and the peripheral nervous system. There's vertebral nerves, cranial nerves, and then the body's motor and sensory nerves. And the ones that we're really concerned about here are the body's motor and sensory. So, quick question: which ones go from the brain out to the body, and which ones go from the body to the brain? Well, the motor nerves go from the brain to the body, and the sensory nerves go from the body to the brain. So, for example, put your hand on a hot stove. The sensory nerve is going to take that pain signal from your hand all the way up to your brain. And then the brain's going to say, hey, dummy, move your hand. And then it's going to send that signal all the way down from your brain, down your spinal cord, out the motor nerves for you to move your hand. So motor nerves go from the brain to the body, and sensory nerves goes from the body to the brain. There's a nice little picture of our central nervous, or our entire nervous system there. All right, so A&P of the head, we got the cranium. If you'll remember, is all of the skull except for the facial bones. Speaking of facial bones, we need to know a few. The mandible, it's special because it's the only one that can move, and it can move because it's jointed, and the joint is the temporomandibular joint, TMJ, the temporomandibular joint. The maxilla is the upper jawbone, the nasal bones. We have the zygomatic arches or zygomatic bones, the malar bones. Those are your cheekbones. And then the orbits, those are what hold your eyeballs in place there, basically your eye sockets there. Spinal cord, we know what that is, right? It's a pathway from the brain to the body, basically, and it exits from the brain through the skull in that big hole at the base of the skull there called the foramen magnum. Hopefully we're all familiar with that term there. We're going to be revisiting that term and that area of the skull shortly. Around the brain and around the spinal column is CSF, the cerebrospinal fluid, right? It bathes and circulates all around the brain and the spinal cord, helps provide nutrients and things like that. If we remember back, the halo test, seeing CSF is a bad sign, right? That means somehow, some way, somebody's been injured enough where that fluid is on the outside of the body. Bad sign, bad sign. All right, here's the anatomy of the head. So some things that we need to know. Need to know the mandible, where the zygomatic arches are, the zygomatic bone is, the nasal bones, the orbits. Um, the main bones of the skull there are the frontal bone, the parietal bone, which basically saddles the skull there. It's basically the big middle part that goes over top of the head down to the other side. We have the temporal bone right there, right basically in front of and above your ears, and then the occipital bone in the back there. And then we have the temporomandibular joint right in there where the mandible is joined with the cranium there. Anatomy of the spine. Hopefully we all have this down, right? 712, 554. You guys have heard that once or twice. So we have the cervical spine, that's 7 vertebrae. We have the thoracic, which has 12, the lumbar 5, the sacral 5, and the coccyx has 4. And each of those has a spinous process, which makes them irregularly shaped bones. What's the spinous process, you ask? Well, you should know that already. It is these things that come off the back of the spinal column right there. You see these things right here? Boop, check out my fantastic art. So those things on the back there, right? They are there for protection. They're also there. That's where muscles via tendons are attached there as well. All right, let's talk about injuries to the skull and brain. Scalp injuries. We talked about this. They can be incredibly bloody. There are a lot of blood vessels in the scalp, so there can be profuse bleeding. It can be a bloody mess. If you've ever seen like a boxing match or a UFC match, some kind of MMA fight, if you've ever had an injury to the scalp yourself or seen somebody else, you know that there can be a lot of bleeding there. For skull injuries, this is going to be like chest injuries, where we're going to classify them as either open head injuries or closed head injuries. Now, let's take a second and think, because they're like chest injuries in these classifications, what makes something an open head injury versus what makes something a closed head injury? Well, an open head injury is if there is a path from the outside world into the skull. The skull has been broken, and so there's a pathway from the outside world to the inside. That is an open head injury. A closed head injury, there's no path through the skull there. So let's think about it. Somebody has a deep laceration on their head, on their scalp. Is that an open head injury? What do you think? No. Not necessarily. If the skull is intact and there's no pathway from the outside world into the skull, then it's not an open head injury. It's just that's an open injury, yes, but it's not an open head injury. Okay, got to know the difference there. Here we see a nice little picture of an open head injury. So this is an open skull fracture. And if you look closely there, we've gone over this, but you can see just how thick the scalp is. It's much thicker than we think it is. Obviously, this is pretty cleaned up. This guy's in a hospital setting there, but you can just see how deep that is. All right, so we're seeing down there into that gentleman's brain. All right, for brain injuries, we're going to have kind of two types here. There's going to be direct brain injuries and indirect brain injuries. And so you can kind of fit everything into those categories. A direct injury, the brain itself is actually contacted by something, okay? Whether it be a foreign object like a bullet, a knife, arrow, whatever it may be, or the skull itself. Maybe the skull is broken and contacts the brain and produces lacerations or punctures or bruising, things like that. So it's something actually contacts the brain, okay? And then there's indirect injuries, okay? Indirect injuries are injuries to the brain that are the result of shock, so impact of the inside of the skull against the brain, okay? So if somebody falls, they fall backwards and they slam their head on the floor, the back of their head, the brain's going to rattle around in there a little bit, and it's going to impact the front and back of the skull. And those impacts could create bleeds or bruising, things like that. Those would be indirect injuries, okay? So the head hit the floor, and then because of that, the brain hit the inside of the skull. So it's an indirect injury. Let's talk about TBIs or traumatic brain injury. These are any injuries that disrupt the normal functioning of the brain. So a couple types are concussions and contusions. A concussion may be very mild. It's a bit of an injury to the brain there. The patient may not even know they're experiencing any symptoms, but they can be pretty significant too. And they can last for months, months and months. Symptoms to include symptoms to include sensitivity to light, nausea, vomiting. There may be memory loss. Either they can hit their head and not remember just prior to hitting their head, or they can not be able to make new memories after their head has been hit there. So a little bit of amnesia there as well. We can also have a contusion. So this is actual bruising of the brain tissue itself. It's been hit so hard that there's actual bruising there. So that means there's been bleeding. So actual bruising there in the brain as well. Now, if we see this little picture here, it's basically saying what we just said. The concussion, they can be mild or they can be kind of severe. So They may have brief loss of consciousness with this, headache, grogginess, short-term memory loss, either prior to the incident or after the incident there. They can have sensitivity to light, and nausea, vomiting, like we said. When somebody actually gets a bruise on the brain, now this is a little bit more severe in that moment. If they're going to have a contusion, they're probably also going to have a concussion to go along with it. But when they get that brain bruise, we're going to see unconsciousness or decreased levels of consciousness there. Maybe they're in and out of it a bit. Maybe they're confused. Maybe they'll have other levels of consciousness changes like that. So again, it's actual bruising of the brain tissue. And both of these are closed head injuries. Now again, a TBI, it's anything that disrupts the normal functioning of the brain. So if you, laceration, right? You think a cut on the brain is going to disrupt function? Yeah, probably there. And then, so that's a type of traumatic brain injury there, a laceration. And we can also have bleeding in the brain. So we've gone over this, the hematomas. We have the subdural hematoma, the epidural, and the intracerebral hematomas as well. It is important that you know what all three of these are and where all three of these are. Now looking at this picture here, we're going to look at the start on the left, the skull on your left there, for the subdural hematoma. If you look at the brain, there's a light blue line basically surrounding the brain there. That's the dura, or the dura mater. It's a covering, it's a fibrous covering over the brain that provides some bit of protection there. But if there's bleeding because of injury that's below the dura, right, subdural, it's underneath the dura, then that's where the bleed is, right? So it's between the brain and the dura mater, as you can see there. Now, just as a note, so everybody's clear on this, you can have a subdural hematoma anywhere on the brain, not just like in this picture where it shows on this patient's right-hand side. Okay, so you can have it anywhere on the brain there. So sides, front, back, top, wherever it might be. Okay, so the subdural is underneath the dura. The bleed is between the brain and the dura mater. You can see it's building up a pocket of blood there. So this particular picture would be a pretty pretty nice bleed that they've got going on there. You can see how the brain on that right hand side is getting squished. Now the next type in the middle here is the epidural. It is above the dura mater, so it's between the skull and the dura mater, and that's where the blood is collecting. That's where the bleeding's happening there, and all the blood is collecting there. Again, building up pressure there. And then the third type, we have the intracerebral. So this is bleeding inside the brain, within the brain there. All right, so different types of hematomas, the subdural, the epidural, intracerebral. Make sure you know what these are and be able to describe them and where they might be. All right, patient care. You gotta, this whole chapter we're going to be talking about mechanism of injury and being aware of it. So, and with that comes the possibility of spinal injury. So if we have brain injuries, we definitely need to be having a high index of suspicion that there's spinal injuries involved also. Obviously, with any patient, open and maintain that airway. Monitor unconscious patients for changes in breathing. Okay, we'll get to that, more of that in a second, but it is important to maintain vigilance in watching their breathing. If indicated with your region's protocols, then apply the rigid cervical collar and do your spinal immobilization there and control any bleeding. Now, think about it here. If somebody's got a big bleed from the head, how are we going to control it? Can we pack it? No, please do not pack a head injury there. So how are we going to do it? Pressure, right? We're going to do it with pressure. But you got to be careful. What if this injury has caused, was enough force that it's caused the skull to break? So we have to be careful about how much pressure we're going to put on this. Are you going to be pushing his skull into his brain? Right? So be aware for crepitus. Maybe feel around gently around the injury site itself to make sure that the skull is in fact intact, and so that you can apply a decent amount of pressure to control that bleeding. All right, let's talk to a conscious patient and then provide them emotional support. It's important to talk to the conscious patient because it's going to help us monitor changes in their level of consciousness. If they're talking to you fine and all of a sudden they start repeatedly asking you questions, oh, how did I get here? Who are you? That kind of thing. Then you know something is getting worse. If they're go from talking to you to using incorrect words or unintelligible sounds, things like that, then you know things are getting worse. So talk to them, keep them involved in the process, keep them talking to you. Obviously, dress and bandage open wounds like we would anywhere, and stabilize penetrating objects. Now, remember, this requires our hay baling technique. Manage any patients for shock if they're bleeding, right? So we lay them down supine, give them the blanket, high flow oxygen, and transport these guys. And then be prepared for vomiting. Use positioning to help with that if you can, if you're able to. It is not uncommon for somebody with a head injury to vomit. Last thing you want is a patient that's backboarded vomiting. Right? So be aware of that. Check in with your patient. How are you feeling? You feeling sick? Feel like you need to vomit? Things like that, so you can be aware. If you are taking care of a patient that is backboarded and vomiting, and they start to vomit, and they're on the cot, unbuckle the seatbelts around the backboard, and then tilt the whole backboard, right? Hopefully you're quick enough to be able to tilt it towards your partner rather than them tilting it towards you, and so you don't have to clean your boots later. But tilt that patient, use that positioning to help keep that airway clean, clear rather, and patent. And obviously this is a high priority patient, right? They may or may not be stable as far as vital signs go, but the mechanism of injury may make them a high priority. So monitor their vital signs every 5 minutes. Get a trend going. It's going to be really important. We'll talk about that in a second. All right, ICP, intracranial pressure. No, not insane clown posse. I'm sure you're all very disappointed. Now, when there's a bleed inside the brain, the hematoma, as it develops, it's going to start getting bigger and bigger, and it's going to start raising the pressure inside of the skull, and it's going to start putting pressure on the brain itself. As the pressure builds, the brain is compressed, the brain tissues are pressed against, and then we start to see neurological abnormalities develop. It can take time for these symptoms to develop, okay, and it depends on how fast the bleed is. So again, it's important to talk to your patient to see what you're not just making conversation. It's basically a test for them, so you can see how their level of consciousness is, right? Are they still able to make sense talking to you? Are they asking weird questions? Are they responding appropriately? Things like that. So it may take a bit, but it could be fast if they have a big bleed. Now, when we do have intracranial pressure, we're going to see two symptoms, two signs rather, that we're going to look for, okay? One is going to be rising blood pressure. Okay, so we're going to have rising blood pressure because it's the body's compensation mechanism, right? We all remember compensation mechanisms and shock, what the body does, right? Things like that. Well, for intracranial pressure, as it's going up, the body's blood pressure has to go up. The body's blood pressure has to be higher than the pressure inside the skull. It has to be higher because um, that's the only way that it's going to be able to pump blood into the brain in order to perfuse it. If the pressure inside the skull is higher than the pressure in the body, the blood pressure, blood will not be able to get into the brain. So we're going to see, as the pressure increases in the skull, the person's blood pressure is going to increase. So you're going to trend it. You're going to see like 140s, 150s, 160s, 170s, 180s. They're going to be really hypertensive towards the end. We're also going to see a slowing heart rate, and together these are known as Cushing's reflex. We've talked about this. So those two signs together, right? Taking their pulse and checking their blood pressure every 5 minutes when you're doing their vital signs, trending these things can show you that the bleeding is getting worse inside their head. We're also going to see an altered mental status as a symptom there. So maybe there's confusion, maybe it's inappropriate words, maybe there's loss of memory. There's all sorts of things that it can be with the altered mental status. Maybe it just works itself into unconsciousness there, and then that unconsciousness works itself into unresponsiveness. Another symptom that we could see or sign is dilated, unequal, or sluggish pupillary reaction. Oftentimes we'll get sluggish pupillary or unequal pupils when somebody has a head injury. And we have Cheyne-Stokes breathing. Now we've watched a video in class of gentlemen in the emergency room with the Cheyne-Stokes breathing there. It is an irregular breathing pattern. Okay, we start kind of fast and shallow, and then it gets deeper and deeper and deeper, the breathing, and fast, and then it stops. Apnea. Now, I can't tell you how long the period of apnea is going to be. It's going to vary from patient to patient, and it could get worse. But then, after a period of apnea, it starts again, right? So slow and fast, or shallow and fast, excuse me, shallow and fast, deeper, 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 and then stops. Okay, that's the Cheyne-Stokes breathing. Now, when we have the hypertension, bradycardia, and Cheyne-Stokes breathing, that's called Cushing's triad. When you have those things, okay, you know for a fact that you have severe bleeding inside the skull. We have a rising ICP, the intracranial pressure, and we're starting to have herniation. Herniation is where the brainstem gets pushed out through that foramen magnum. There's pressure being put on it, and once the pressure is being put on the brainstem and parts of the brain, right? What's the breathing center of the brain? That's right, medulla oblongata. Very good. I knew you knew that. So once we get there and we have the Cheyne-Stokes breathing, we know for a fact that their pressure is being put on that brainstem there. So really bad situation when we get to there. We can also have those ataxic respirations, which are completely irregular. You can't tell what their next 20 seconds of breathing is going to be like. It's just completely irregular. Once that brain continues to herniate and get pushed out that foramen magnum, we're going to get the decorticate and decerebrate posturing with that herniation. Now, if you remember, we watched the video of the gentleman that got hit in the head with a sledgehammer, right? And he immediately had a type of posturing. Now, his posturing, if you remember, his arms were kind of out in front of him, and his wrists were turned to the outside. His wrists were turned out. What posturing was that? What kind of posturing was that? Yes, very good. That was decerebrate posturing. Okay, so decorticate, they will basically almost flex their arms. They're going to bring them into the core of the body. That's how I remember, right? They bring their arms into the core of the body for decorticate posturing. Decerebrate posturing, they're moving their arms out and away from their body. Their wrists will be flexed outwards like that. Now, obviously, with that guy that got hit in the head with the sledgehammer, that was immediate. The onset of that was immediate. As soon as his dome got dinged there by that sledgehammer, he was immediately showing the decerebrate posturing. But it could also be delayed in the onset as the progression of the bleeding inside the brain and the pressure and herniation, et cetera, for all of that progresses, then we can get that posturing as well. All right, a little bit of think about it there. So, do they have a potentially serious head injury? Should they be treated to a trauma center? Should they be spinally immobilized? Is it warranted in these cases? Now remember, these things we talked about Liam Neeson's wife who skied into a tree, right? If you remember, ski patrol said, nah, you're good. You can go on home. She just got a headache, right? She's okay. Well, she ended up dying later that night because she had a brain bleed and it continued. So have a high index of suspicion. If they're like, yeah, I'm okay, my head just really hurts, but the mechanism of injury was, sketchy, there's a high degree of impact or force applied to the patient's body, then you know what? Get them to the hospital. Let's get them to there. Let's be wrong. Okay, I'd much rather be wrong in saying that. Well, let's just get you checked out, than be wrong the other way by letting them go home and then they die in the middle of the night. Okay. All right. So injuries with objects that are impaled. All right. It's the same thing as anywhere else in the body. Stabilize the object in place. Maybe use the hay bale there. And if it's a long object, right? Like let's say somebody's got a 4-foot piece of rebar sticking out of their head. Well, you're probably not going to be able to transport them like that. So um, that may have to be cut. You have to get the additional resources there. Get the fire department to cut that down in order to transport them. I believe we watched a video of a guy that had the pipe through his face, right? The piece of the fence through his face and how that had to get cut down. Obviously, we're not removing anything. So unless it's something that's through the cheeks, you can see both ends, and the bleeding is causing airway issues. But otherwise, we're not removing anything. Injuries to the face and jaw, obviously we have to worry about the airway. There can be a lot of bleeding there. There can be disfigurement, things like that. So we have to worry about the airway, be prepared to suction, and use positioning when possible to help with that airway, right? If they're able to, and we don't need spinal mobilization, then put them left lateral recumbent. Put them on their side. Allow that drainage to come out instead of going back down into their airway. So there's non-traumatic brain injuries. Basically, you can have a stroke. A stroke is a non-traumatic brain injury, right? There's a bleed, there's a hemorrhage, there's an occlusion, there's by blood clot. So these are a non-traumatic brain injury, basically a stroke there. And we know what the signs and symptoms are. So anybody that has a brain injury where there's a bleed, they can have signs and symptoms of strokes, right? So maybe they can't smile very well. Maybe there's weakness on one side of their body. Maybe there's paralysis or paresthesia on one side of their body. Okay, they can have all the same things, except there's no mechanism of injury here. They just started feeling these symptoms. Okay, just like a stroke. All right, here's something that we need to know: is the Glasgow Coma Scale. We use this in conjunction with AVPU, right? Alert to verbal, alert to painful stimulus, and unresponsive for a neurological assessment. This is more in depth than just AVPU, just saying they're alert or they're unresponsive or they're responsive to verbal, whatever it is. It's more in depth there. You have to know this. You have to know how to score somebody. Okay, there's a chart coming up here that you'll see, and we'll talk about it here. But essentially, there's three things that we need to consider. The first thing is how they move their eyes, how they open their eyes. The second is how they're talking to us there. And then the third is their motor response and how they're moving or localizing pain or withdrawing from pain if they're unconscious. You need to know how to do a score. You have to. When you're taking a patient to a trauma center, they're going to ask you. So you got to have one. However, keeping that in mind, don't spend time on the scene calculating that. Right? It should only take a few seconds to calculate one once you know this. So don't spend a lot of time doing it. Don't waste time getting the patient into the ambulance and transported because you're trying to figure out their GCS. All right. So, but you do have to know what it was. Hospital was going to ask you for this. Here's a handy dandy little chart here that is going to make sense of it. Okay, so for the Glasgow Coma Scale, again, we're looking at three things. We're going to be looking at eye opening, their verbal responses, and their motor responses. So let's tackle the eye response column first. Actually, let's back that up. Let's talk about it in general. The best score that you can have here is 15 points. We are all 15 points right now. Okay, we get 4 for our eyes opening simultaneously, 5 for being oriented, and 6 for obeying commands. All right, now as you go down the scale all the way to the bottom, you'll see that each column, the lowest score you could possibly get is a 3. 1 for no eye opening, 1 for no verbal response, and 1 for no motor response. Okay, so a dead person gets a 3. All right, they don't get a 0, they get a 3. All right, so the best you can do is 15. The worst you can do is a 3. All right, so let's look at the eye opening. So if somebody's acting normally with their eyes are opening spontaneously, that you walk into a room and they look at you, then they get a 4. That's a 4. If you have to yell at them to wake them up, they get a 3. Say, hey, buddy, wake up, you okay? And then they open their eyes at you, they get a 3. If they don't open their eyes when you're like, hey, buddy, are you doing okay? Wake up. And you have to give them a little bit of pain, then they get a 2. If they open their eyes when you give them a little bit of painful stimuli, then they get a 2. And if they don't open their eyes after that, they get the 1. Now for verbal response, 5 is oriented. Okay, it's your normal level of consciousness. They're oriented to person, place, time, and events, right? 4 points for if they're confused a bit. 3 points for inappropriate words. Ma'am, can you tell me what happened? And she says, purple monkey dishwasher, right? That's not appropriate. So if they're using inappropriate words in their responses, then she gets a 3. If it's incomprehensible sounds, moans, groans, guttural utterances, whatever they may be, incomprehensible sounds, they're not forming words at all at this point, then they get 2 points. And if there's nothing, they get 1. Now for motor response, this is a little bit more brainy here. You got to kind of know what's going on. So 6 is normal, right? You obey commands. Sir, sit down. He sits down. Ma'am, can you stand up? She stands up. Sir, can you put your arms out for me? Hold them out in front of you. Close your eyes. Hold them out. If he does that, then he gets that 6 points, right? Obeying commands is normal. They get 6 points. Now, everything below this, you can pretty much consider them unconscious below this, okay? Localizing pain at 5 points, you have an unconscious person and you go ahead and let's say you pinch the back between their neck and their shoulder, right? That little pressure point back there. If you pinch that, give them a little bit of pain, a little painful stimuli, and they roll their head and their shoulder kind of towards that pain, right? Towards that side where you're doing it, that's localizing pain. They're moving towards the pain, right? They're localizing it. Now, if they get 5 points for that. Now, if you pinch them, same place, but their head goes away from the pain, that's withdrawing from the pain. That gets 4 points. Now, let's say you have an unconscious person there, and you go ahead and you pinch that neck, right, that right behind the shoulder there, to see if you can get a response. And in response, we have number 3 here, flexion in response to that. That's decorticate posturing. Somebody has a head injury, you give them a painful response. Maybe they go into decorticate posturing. If they do that, that's flexion, okay? If they do that flexion, the decorticate posturing, they get 3 points. 2 points is the decerebrate posturing. They're extending, is that even a word? Extending their arms a bit, right? They're rotating their wrists outwards. They're extending like their arms like that. That is the decerebrate posturing, so they get 2 points for that. And then 1 is no response. So for the motor response, 6 is normal. 5, they move towards the pain. 4, they move away from the pain. 3, they're going to move back towards the core of their body with their decorticate posturing. 2 points is they're moving away from the body with the extension, the decerebrate posturing, and then 1 is no response at all. All right, so let's look at this for a second. If 15 is us and it's normal, how bad off do you think somebody is with 13 points? All right, take a second, look it over, and then figure out, try to add somebody up to 13 points and think about how well off they are or how poorly they're doing. All right, so I'll do it here real quick for you. So if we have somebody, let's give them they obeys commands, right? So that's 6 points right off of the bat. That's good. All right, they're obeying commands. Let's say maybe they are they're confused. Let's give them 4 points, all right, for their verbal response. So that's 10 points total. So they're obeying commands, but man, they're confused. They don't really know what's going on. Well, how many points do we have left? Right there for 13. We only got 3 points left, so we got to give them opening eyes to speech. So that means they're in and out of consciousness at 13 points. Now, this particular person, anyways. So is that good? Probably not. They're probably having a situation there. So it can go from very normal at 15 points to problems very quickly. All right. So take a moment, pause this, and then find out 10. Get a patient, figure out, give them one selection from each column, give them 10 points. Figure that out, and then see how bad they are. And once you're done, go ahead and unpause it and then start back again. All right, let's talk about wounds to the neck. As we know, the anatomy and physiology there for the neck, we have 2 big arteries, right? The carotid arteries going up to feed the head and the brain with that vital blood. And then we have 2 big veins coming down from the head, the jugular veins, right? One on each side, bilaterally located. Now, obviously, we know that there's arteries are under high pressure. So these big arteries get cut or severed in an injury, then we're going to have lots of bleeding there. And we can also have lots of bleeding for a large vein, but here's the thing. The veins, the pressure in those large veins, it's lower than atmospheric pressure. What in the world does that mean? Well, that means that the air around us, right, it's at a higher pressure than what's in those veins going by there. So when somebody has an injury that opens up one of those large veins, they can actually suck air in. Right? Remember, things go from higher pressure to lower pressure. If you blow up a balloon, It means there's high pressure in there, right? And if you open up the end of it, right, air doesn't go sucking into that. The air goes from the high pressure to the lower pressure and it comes shooting out. So when you have a large vein that opens up, it can actually, the air from the atmosphere can actually go pushing into that vein. It can get sucked in there. Now, that's a problem. Problem is that it could cause an embolism, a pulmonary embolism. We have a large air bubble in the system now, and that's bad news. We can have a blockage. It can occlude blood flow in the lungs, even in the brain if it gets all the way up to the brain there. Okay, so we have to prevent that from happening in our treatment. So for the patient care and the treatment of wounds to the neck, we're going to ensure an open airway. We've got to think about the airway. It's right there, right? Do we have any problems with the trachea or anything else like that? Is our airway patent? Is it going to stay open? Now, if we have large bleeds to obviously to the veins or the arteries, all right, we gotta stop that, stop the bleeding clearly. Now, if it's a large vein, we're going to use our techniques from an open chest wound. We're going to place a gloved hand over the wound. Then we're going to apply an occlusive dressing. Right? We remember that from the chest injuries. We're going to apply dressing over top of the occlusive dressing and then keep applying pressure. Once we've stopped the bleeding, then we can bandage it in place. Please don't strangle somebody with the bandaging. Keep that in mind, right? Don't just wrap it right around their neck. Now, if mechanism of injury suggests, then we'll have to do spinal mobilization as well. All right, injuries to the spine. All right, injuries to the spine. So assume that there's C-spine injuries based on the mechanism of injury. If we have a lot of force applied to the patient at the shoulder level or above, it's a good rule of thumb that if that they may have a cervical spine injury if that happens. So here's some mechanisms of spinal injury. We have diving injuries, right? You can kind of include falls in here as well because you don't have to just dive to get these type of injuries. Maybe you fall off a ladder or something like that. Impacts with the windshield. All right. So if you remember back to mechanisms of injury with that, or the patterns of injury rather, the up and over. So if somebody's not wearing their seatbelt and they go up and over, their head can hit the windshield. And if you look at the picture, we can see the telltale spider webbing or starring of the windshield there. And then the bottom picture there, the lady's just getting a little bit of whiplash there. So those are some mechanisms there that can cause injury to the spine. So obviously, with spinal cord injuries, spinal cord injuries, there can be potentially devastating consequences. So paralysis, permanent, lifelong paralysis, there are obviously devastating. Death would be another one. I'm sure that's pretty inconvenient for people being dead because of one of these. So that is a devastating consequence. I think that's understating it, devastating, that word there. So we need to really keep in mind, as we already said, the mechanisms of injury there and the physical condition of the patient. So how are they doing? Do they have neurological deficits happening there? What's their level of consciousness like? All right, so some mechanisms of injury that are high risk. We have falls of greater than 3 feet or 1 meter. Now you might say I could fall, from like a standing position or on top of a table or something like that and be all right. Well, you might be, but what if you fell directly onto your head? And that's a different type of story there. So you could definitely have serious injuries from just that high. We're going to consider 5 stairs to be the maximum, right? So or the minimum are there for high risk fall. So if they fall down 5 stairs or more, then that's a high risk MOI. Axial loading. This is compression injuries. So that means somebody, for example, dives into a pool and they hit the top of their head and all that force presses their head down into their spinal column and the pressure goes down their spine there. The force travels down their spine. You can break your neck like that and obviously sever the spinal cord. High-speed motor vehicle crashes, especially rollovers and or ejection of the patient. So high-speed vehicle crashes, a lot of force can be applied to the head and neck causing spinal injuries. If there's a rollover, even if they're belted, there's going to be a lot of pressure or forces applied to their head and neck, and so they're susceptible to those injuries. And if somebody's obviously thrown from a car, then we absolutely have to consider that that mechanism of injury is enough to cause a spinal injury. So the energy that forces movement of the spine beyond its normal range of motion, things like whiplash, we're hyperextending and hyperflexing our neck like that, that can cause injuries. Now, certain medical conditions can exacerbate these things. So we might be able to have like a normal range of motion. Maybe you guys more than me, but maybe an old lady with kyphotic, right? They have kyphosis. You've seen these old people, right? They're walking around at the store or something, and they're all hunched over, they're bent over, they can barely look up, right? You think they have a good range of motion with their neck or their spinal column? Probably not. So maybe they only need a little bit to get into an area where we're having severe trauma or damage there, much less than we would need to injure our spinal column. Some other high risk stuff. So ATVs, folks, ATVs are just killers. People go over the handlebars, they get flipped over on, things like that. There's bicycle collisions. If somebody's hit by a vehicle, all right, they're hit by a car, they're hit by a bus, something like that, then you have to maintain a high degree of suspicion that spinal injuries are involved there. And these are just a few of many. So it's all about the mechanism of injury, really, and assessing that. So we've got to know how they got hurt to properly get an assessment done. So the physical assessment of what we're going to do is we're going to palpate it, and pain and tenderness, especially in the center line there. So as we palpate the neck, we're looking for step-offs and pain and tenderness along the midline, it's called, all the way down the neck and all the way down the back there. Dermatomes, the book has a nice little part in that, but we don't have to worry about that too much. Obviously, paralysis of the extremities is no good. So that being a finding, and it's a major finding there. There's changes in neurological function. So obviously, paralysis is one. But what about paresthesia or numbness? If they're having pain in their back, with or without movement. Tenderness anywhere along the midline of the spine, and any impaired breathing. Why would their breathing be impaired if they have a spine or spinal injury? Well, maybe they broke their spine or had a spinal cord injury high enough where their diaphragm is not properly innervated any longer, and so they have a hard time doing the actual process of the breathing. So keep an eye out for impaired breathing when there's spinal injuries as well. We may have to PPV them, right? Positive pressure ventilations, bag valve mask these folks. Priapism, as we know, is a sign in men of a spinal cord injury. They can also either pee or poop themselves. They've lost muscle control there if the spinal cord has been severed or injured at a higher level than where that's innervated. Obviously, if there's obvious deformity of the back, right, or if we see signs of shock, maybe they're going into neurogenic shock. We should remember what neurogenic shock is there. If you don't, go ahead and look that back up. As a geriatric note, we got to know at this point that old folks, they're frail, they can be brittle, they can get injured with mechanisms of injury that are far less than a healthy young person there. So they can injure themselves and fall, and so have a higher index of suspicion for head or spinal injuries with the older folks. Okay, for patient care, manual inline stabilization. Somebody get C-spine, right? Get it right away. Take care of the ABCs while somebody else has the C-spine there. And then assess the head and the neck, and if need be, apply that rigid cervical collar, the C collar there. And then check our PMS, right? Pulse, motor, and sensory function. Apply, if necessary or inappropriate, the appropriate spinal immobilization device. And then reassess PMS at the end, right? Always reassess once we've applied a splint to the body. So spinal immobilization, we've gone over a bunch of this, and we've talked about it that a long time ago, even when I started, that we used to put everybody on a backboard, right? You sneeze too hard and your back feels weird, you put them on a backboard. Maybe that's an exaggeration, but it used to do it for a lot of people. And the science is coming out that we may be doing more harm than good. And so things have changed now. Okay, so we're not doing it as much. I will email you out a link to our region's spinal algorithm, spinal mobilization algorithm, so you can see how what we use now in order to decide whether or not somebody gets the backboard. Now, keep in mind, if we do have a spinal injury, there could be secondary injuries caused by it. So let's say somebody's diaphragm isn't working right? They've had a spinal injury above where the nerve comes out for the diaphragm, and so they can't use their diaphragm very well. Might they get hypoxic? Yeah, sure. You might need to give help them breathe, give them some supplemental oxygen. Could they be going into shock because most of their body is now paralyzed? They can't innervate any of their blood vessels, and so they're all dilated. All the blood vessels are dilated, and so their blood pressure is dropping through the floor. Hopefully you looked up neurogenic shock, because that's what it is. Let's see. The evolution of spinal care, we can go ahead. All right. We're going to go through this a little bit. A lot of this backboarding stuff, please read over. We've talked about it many times. You've backboarded many times, so you know exactly what's going on. The collar, what's important about the collar is that it's appropriately sized and appropriately put on. That head should be in a neutral position, not tilted back, not able to look forward. We've all been in one. We know exactly what it means to have a correct collar on there. It should, you know when it looks right. You know when it looks right. Okay, let's go to spinal motion restriction issues. Um, so putting them on a backboard may be difficult. Not everybody is in the perfect anatomical position. They could be crumpled up in a manner. They could be they could be laying face down with their head tilted to the side. So how are you going to get them turned over and keep C-spine in line as you log roll them onto a board? How are you going to put on a collar? Right? If they're crumpled up somewhere in an awkward position, they're face down, things like that. So those are issues that come up, and you have to be aware of those. Like, again, that not everybody's going to be found in that perfect anatomic position. For an infant or child, there are pediatric C-collars like we've seen, but they may be too big for the little kids. So you may have to roll a towel, wrap it around kind of like their neck. Like, don't strangle them with it, obviously, but kind of wrap it around the neck, and then you can tape it in the front. The two ends of the towel, you can kind of tape that together in the front. That's going to give them a good support around the neck there. Just don't make it so they can't breathe. Okay, so this little part is if they're in a seated position, then we're going to could use a short board or a vest. Hardly anybody uses this anymore. If they're high priority, then we're going to manually stabilize while moving the patient, and we're going to put them on a backboard. We're going to go through this here kind of quickly here. So when you're taking them out of a car, when they're sitting in like, say, the driver's seat, you get manual stabilization, you do your assessment, you put on the collar, and then you get the head out first, or excuse me, you get the torso first, and then the head last when you're securing them there. Now, as you're getting them out of the car, you're going to lay them down. So you're going to get the head out first. You may have to pass C-spine from one person to another and then lay them down like that. This is a skill that you're going to have to learn outside of class, unfortunately, there, but it is an important one to know. All right, these are just the steps in backboarding somebody, and we know these, so we're going to skip through them quickly here. Okay. For backboarding somebody that's standing, now you're probably not going to have to do this all that much because of the new guidelines in place for backboarding people, but you may have to backboard somebody that's already up and around, that's standing. So it takes 3 providers, a collar, and the board the rapid takedown, it's called. So somebody will be getting C-spine from behind the patient. You're going to another provider is going to take the board and stand it up right behind the patient there. And then, so we have one person holding C-spine behind the patient, and then two people in front of the patient holding the board, and you slowly walk that patient down, just like if the bottom of the board was connected to the ground, you slowly lay them down on top of the board there. It's a nice and slow, nice and easy thing there. It's called the rapid takedown. Look in the book. There are videos, excuse me, not the book, the multimedia section of My Brady Lab. There are multiple videos in there on how to do a standing takedown and how to backboard, etc., etc. Here's a picture of how they're going to do that. So we have the guy behind. He's holding C-spine. He's got his face on the board, so it gets awkward on how to do that. And then these two guys in the front, they're going to be holding the board steady as they let her down there. Here they go. See how it's getting awkward for the guy in the back? Okay, patient found wearing a helmet. If it fits snugly, it should fit snugly if they're wearing it appropriately. Listen, if they've got a helmet on, we can leave it on unless it's causing problems with the airway. If we need to do stuff with the airway, then we need to get the helmet off. Okay, you can properly immobilize somebody wearing a helmet. You don't necessarily need to take it off. So if they, excuse me, if they've got a motorcycle helmet that doesn't have a full face shield, or you can access their airway there, you can leave it on. You don't have to worry about taking it off. However, if there's any breathing or airway issues, then we'll have to take it off there. So I'll do my best here. Sorry about that. Went a little too far there. I'll do my best to explain taking the helmet off really quick. One provider is going to take C-spine like we normally do, holding the helmet. A second provider is going to slide the hands up into the mask and basically grab C-spine by holding onto the patient's face. Then the person that was originally holding manual C-spine from behind, they're going to grab the helmet and they're going to pull straight back on the helmet to pull it straight off. Now, the problem here is the issue that could happen is that helmet is elevating that person's head a couple of inches off the ground, and so the provider holding that face of the patient, they have to have their hands kind of down underneath their head, their neck there a little bit, and so when they pull, the helmet gets pulled off, the head just doesn't clunk down onto the ground there. Now, when you're pulling the helmet off, you got to be aware that's going to clear the nose. You may have to adjust slightly your angle to clear the nose. Okay, that's the chapter. Hopefully you got something out of that. Let me know how it went for you guys. I'll be doing the rest of the chapters like this somehow. And you'll be seeing the assignments roll out with these as well. We'll be having meetups this week on Zoom. I'll send you more information there. And then we can ask questions and go over this. We can do a little online review before you sit down and take tests. We'll figure that out. Let me know how it goes.